Welcome, Mr. Aneel Bhangu. Mr. Bhangu is a senior lecturer at the University of Birmingham in the UK, and he has data to present on the trial that he's coordinated on COVID surge, something that is critically important to all of us at this point in time. Welcome, Aneel.
Thank you very much, and it's nice to talk to you today.
Thank you. Well, you had presented to us on the AS channel a very interesting topic, which I thought we'd like to give more time to explore, and that is the COVID surge trial. Perhaps start by explaining to everyone the nature of the trial, how it was designed, and what was the intent at the time of design.
So it's an observational study, and there are two arms to that observation. The first group of patients are those who undergo surgery and have a perioperative diagnosis of COVID. So we want to see what happens if you get COVID around the time of an operation. The second study is looking at elective cancer surgery, so across all types of surgery, and that will look at patients who are negative for COVID to start and what the in-hospital transmissibility is, and then what the mortality outcomes associated with that are. There are really two things we're doing differently in these COVID surge studies. Firstly, this is a true global collaboration. One or two hospitals' data just isn't enough to pick up the signals and pick up the messages. So we are uniting surgeons and fundamentally patients from around the world. The second model we're shifting is we're moving away from collecting data, then spending 6 to 12 months to get it published, because we need this information now. We're trying to quality control it as quickly as we can. So there's methodology quality control. So we want confidence in the data we're releasing, but we want to release it as real time as possible, because you and I share the same problems in decision making, and fundamentally that's the problem our patients have too.
Towards that end, how many institutions and from how many countries are those institutions participating?
So we've now got 89 countries contributing data. We have 3,000 unique surgeon email addresses registered with us. And what's really interesting is that it's bringing together surgeons as teams within the hospitals. So when we talk about surgery, we are working across all branches of surgery. In our first cohort study, we've got GI surgery, cardiac surgery, neurosurgery, head and neck, thoracics. We've got all the different branches, orthopedic surgery. And that's forcing teams in hospitals to work together so that they can coordinate data upload. And that's been absolutely fantastic. It showed leadership, it showed team working, and it's working across these boundaries, typically in surgical specialties who might not communicate every day.
How many patients have been entered in the registry to date? Actually, to put that in context, perhaps you could start out letting people know at what point the registry was officially launched, and then how many people have been entered as of today, recording on April 20th.
So we are as real time as we can be. We started this around the first week of March. That's when people started entering their data based on the first COVID case in the hospital. And really that represents the EU-USA phase of the disease. So at the moment, most patients are from the UK, Italy, Spain, USA. I think as time goes forward, we'll see that broaden. We're now seeing a lot of cases coming in from Turkey. We're looking to launch the study across India and Africa. And really that will allow us to monitor real time what's going to happen as the disease spreads around the world.
How many patients have been entered for the month of March and the first 3 weeks of April?
So in total, we have got over 1,000 cases, of whom about half of them have achieved 30-day follow-up. We've been working with sites to ensure as much as possible that these are consecutive cases within the sites, because that's key. If the site only submits their COVID mortalities, then the post-operative mortality rate is artificially inflated. However, what we are seeing is that each week the data comes in, there's a consistency in the mortality rates and the case mix. So within reason, we've done everything we can to make sure that this is consecutive cases coming in.
Okay, thanks very much. At this point, perhaps you've whet people's appetite enough that they'd like to hear some of the findings from the initial data cohort with 30-day follow-up.
Yeah, and so what we've done is we've hit about 500 patients with 30-day follow-up, and we feel that this is the right time to release the data. The headline messages are, firstly, post-operative COVID pulmonary complications are lethal in patients having undergone surgery. Before COVID, we knew that about 10% of all patients would get a pulmonary complication after an operation. Of that 10%, about 3% would die. So it's actually a small number. During COVID, we've identified that of those who get a COVID pulmonary complication, that's 67% of patients who have the SARS-CoV-2 infected state. So a lot more of these patients are getting a pulmonary complication. And of that 67%, 33% will die. So we've managed to unpick a little bit of the phenotype of the disease, and that is it has an aggressive post-operative course.
What is the overall mortality in patients who are COVID positive undergoing surgery?
It hits about, depending on which group you look at, it hits about 25%. We can begin to unpick some of the risk factors for that. In our series, no one under the age of 50 died, for example. No one under the age of 50 who underwent an operation died. So these deaths are all over the age of 50. So as patients get older, as they undergo an increased size of operation, and if they're undergoing emergency surgery, those are all risk factors for increasing mortality.
Have you had an opportunity to look at some of the other risk factors which are commonly cited, such as hypertension, diabetes, obesity, immune suppression, cancer?
No, we haven't. And so, again, this is a new thing we're doing. We're going to flip to a phase 2 of the cohort study, and we're going to introduce some of those factors that seem to be interesting and important for patients. So BMI, some more of the medical comorbidities. There is some concept that a TB vaccination will provide some benefits to patients. So we're going to insert those variables from here going forward, because we are getting hundreds of patients a week coming through into the cohort study. So it's a unique chance to gather that information.
And of the patients who are undergoing surgery, so 25% mortality of 500 patients, what percentage of patients are not known or suspected to be COVID positive prior to their surgery?
Well, if we look at I'll talk about our elective cancer study for a moment. So again, that's across all specialties. Of those 500 patients, only around 50 patients of those had symptoms leading up to the point of surgery. And actually that's from the really early days, and about 50 patients underwent surgery with symptoms. The rest of them, the majority of patients, are asymptomatic at the point of surgery. And that's the group that are going to cause us the most concern going forward. Now, of that group who we'll call without COVID, COVID-free, 15% of them develop the in-hospital infection. That's the SARS-CoV-2 status. So they pick up the infection in hospital, 15%. Of that 15%, again, it's consistent with what we're finding. 2/3 of them go on to develop a COVID-19 pulmonary complication, which is associated with the high mortality.
If that's the case, obviously it is the case in your study, what is the role for routine preoperative COVID-19 testing?
I think so. 2 of the signals we picked up from this study. Firstly, it looks like the rate of COVID pulmonary complications is very low when elective surgery is carried out in a COVID-free environment. And so that environment stems from everything: the patient, the surgeons, the team of medics looking after them, the theatre staff. So that COVID-free environment seems to be really important. The role of testing is difficult, and my experience is to advise caution. I have seen a lot of recommendations coming out, and I think we will see pros and cons of all of those. For example, it looks like there will definitely be a role for preoperative testing. If that's done with nasal swabs 48 hours before the operation, some thought needs to be put into where that swab takes place. If the patient's brought into a hospital for that swab and that hospital has COVID, the patient is potentially exposed. There will probably be a role for preoperative CT scanning. Again, if you bring the patient in the day before, they're exposed to an environment. Some hospitals I've spoken to are doing it in a clean scanner on the day of surgery. We're moving into a phase 2 of the cancer study where we are going to collect data on exactly who is doing which form of preoperative testing. And I think that will real time unpick these different scenarios for people. Until that point, I would advise caution and advise people to do what is locally sensible.
One of the questions about mortality is, are all of those mortalities, the 25% mortality, directly COVID-19 related, or there are ones that are non-COVID, somebody fell out of bed and got a subdural, whatever the case may be?
93% of people who died in our studies are dying with a COVID-19 pulmonary complication. So those complications are pneumonia, ARDS, or unexpected post-operative ventilation. And of those, it's the ARDS that is the most lethal. So I think we can make a relatively safe assumption that it is those complications that are leading to most of the deaths in these patients.
Thinking about all of the data together, it seems like the overwhelming majority of patients are not known to be COVID positive prior to surgery. They're found out subsequent to surgery to have COVID positivity. And if they acquire COVID, they've got a tremendously increased risk of mortality. How do we put all of those data together as we start to ramp up, as either we're past the curve or we accept that this is our new normal way of doing business because COVID-19 in the absence of an infallible vaccine is really not going away. So how do we accommodate and how do we take care of our patients in the context of these data?
And I think you said the important thing there. I have been phrasing this in the way I would speak to my patients, because what I don't want our patients in the community to think is, I'm not going near a hospital for my operation, it's too dangerous, I will sit at home with my disease, I won't seek any help, because I think that risks doing just as much harm. So the message I'm giving to my patients is that we're in a phase of real-time learning. So we are collecting data, and I would encourage all of your listeners to contribute their data. Real-time learning and real-time change. For example, we are learning already that COVID-free environments are going to be important to elective patients. We are learning what the role of preoperative testing is, and as soon as we have more firm information and that comes in, we will release it and we'll harness that from around the world. But my message to patients is that the doors need to reopen, and we will do what we can as a community to make surgery as safe as possible. So this concept of group learning and global learning and webinars and releasing data quickly, I hope that also becomes the new normal.
Thank you very much for sharing your time and sharing the results of your very critically important study with us. I certainly look forward to seeing this first article, and I'm sure many subsequent articles, in press so that we can all cite them, we can all learn from them. Perhaps you could share just a few particulars on how the viewers and listeners can register their patients.
So the easiest way to register is to go to our website, which is www.globalsurge.org/COVID. And actually the full range of studies is there for you to have a look at. Protocols are there and register. It's done as a sort of menu because I know people are going to be under different types of pressure at the moment. So there are the smaller studies, and then there are the more involved cancer studies. But we've got a really good proactive team, which is international, and we're happy to hear directly from people and give them some guidance.
Thank you very much again, Aneel, for your time and expertise. Congratulations on your important work. Wishing you and your loved ones sustained safety and health, and look forward to seeing you in person when all of this problem is hopefully behind us.
And the same to you. Thank you very much. It's nice to talk today.